Yes, please.
Yeah. Uh, I would actually like it to be interactive, but since people would normally hesitate to ask questions, just to set the context, I'll probably present a few slides. Um, so we'll start there, and people, if they want, they can ask questions in the chat, and the moderator will ask all the questions, then I can answer them.
Yes, please. Questions
That's
to be welcome. Thank you so much,
yeah,
Doctor.
yeah. That's what we'll be doing. I'll just share the screen. You're able to see the.
Yes.
Are you able to see the screen?
Yes, please.
Yeah. So what we are going to talk when we say dealing with denial.
Clinic Chennai, sir. Consultant psychiatrist. Mohan Raj.
Yeah. When we say denial, see, denial, whoever knows psychology knows about denial in the psychology literature of Freud, totally different. We are not talking about that kind of denial. We are talking about when people deny various things, like it could be about, we'll look at some of them. What are all the things we are denying? And the structure of the talk is like, what do we deny? We meaning patient or the caregiver. What are the things that we deny? And let's briefly look at why do we deny, and who is the one who's denying? Is it the patient who's denying, or is it a family member who's denying? And how do we deny? How do we, what are the things that we use to deny? And then importantly, what can we do about denial? Like as a support group, how can you convince the patient person or the family about what can they do about the denial? So that will be the basic structure. So when you say what do we deny, one is denial of problems. Like I don't have a, many people say I don't have a problem at all. Especially true when we are talking about psychotic disorders, like when they have delusions, hallucinations, they feel there are people trying to harm them, there is danger, there is a conspiracy, where they will feel there is no problem with them, but it's things from outside. There are people who don't even talk about hallucinations or delusions because they know that they will be told they have an illness. So they will say everything is fine. Family members bring, they will not even open up and give a history. Now, not only with psychotic symptoms, this can happen with depression also. There are people who say, I'm absolutely all right. I don't know why my family members have brought me here. Or with substance abuse, that they'll deny there is a problem, they deny there is a substance abuse. I don't know why the family has brought me here. So there are a lot of people who reach the clinic and say, I don't know why my family has brought in here. This is about people who have reached the clinic. You have a lot of people who don't reach the clinic because sometimes the general practitioner will say, please see a psychiatrist, but they will say, absolutely no problem. Why should I see a psychiatrist? Or others say that, please see a psychiatrist, and they'll say, I don't have any problem. Now, the second is denial of symptoms, that denying that I hear voices, because if I say I hear voices, then they're going to take some action based on that. They might give me medicine, they might admit me. So there are people who deny symptoms. And this doesn't happen only with psychotic symptoms. As I said, there are people who deny depression, there are people who deny anxiety for various reasons. Then you have denial of diagnosis. There are people who say, I don't believe something called depression exists. Like, I don't think there is depression. Psychiatrists, psychologists are trying to package normal sadness and sell it as depression. So there are people who take that stand that there is nothing called depression for various philosophical reasons they have. We look into them. Then There are people who have mania in bipolar disorder who will say, no, I'm just being creative. There's absolutely nothing wrong with me. I'm just creative. I'm doing things. I have more energy because I'm doing my exercise regularly. I'm taking care of my diet very well. And that's why I'm like this. I don't have mania. It'll be pretty tough to make them understand the diagnosis. Or a person with psychotic symptoms will say, no, I don't agree with the diagnosis of schizophrenia. And because this is actually happening. It's not my problem. It's my neighbor who's trying to harm me. I don't have a problem. So denial of diagnosis, very common. Many times people will deny when we tell them the diagnosis. And I'll tell you how we can go about it. In this context, maybe I should digress a little bit about and tell a couple of things that happened. Once there was this young girl who was about 20 years, college student, who kept telling her parents, take me to psychiatrist, take me to psychiatrist. And they all knew me because I was treating the grandfather. So it's not that the family does not know about psychiatry. The parents kept delaying. And by then, she was harming herself, she was cutting herself. Then, when she came in, I talked to her. Mother kept telling, no, you don't have anything. You're just trying to avoid your homework submission. Somebody has to be muted. Ganesh, can you take her? Yeah. So what happened was I talked to the girl. She was very severely depressed. She was suicidal. She has been harming herself. And after talking to her alone, I called in the parents, and in the presence of the parents, I told she's severely depressed and she needs treatment. And the mother immediately said, oh, she managed to cheat you also. So I explained the symptoms to the mother and said, your daughter has been telling you for the last 6 months about depressive symptoms. You don't want to believe her. Now, I, as a psychiatrist, have talked to her, and I am saying that she's severely depressed, and you don't want to believe it. What more can I do? And the mother asked me, is there a blood test for depression? So that's the kind of denial sometimes family members have. The patient wants treatment, whereas family members will say no. Then sometimes there are a lot of people, this is not limited to psychiatric illness, physical illnesses. When people are asked to do tests, they don't do it for various reasons. They feel, oh, if I do the test, if it's positive, I'll have to be in trouble. So if it's sugar, they will not do sugar. If thyroid, they will not do thyroid. This is across all physical illness. There are people who just postpone doing tests because they're afraid the test might show up some negative results. We'll talk about why they do it later. Then denial of treatment. Yes, I agree that I have a problem, but I don't want the treatment that you're suggesting. I don't want medicines, or I don't want therapy. I'll do it some other way. They talk about a lot of other methods by which they would want to take treatment. So these are the things they deny. As I said, denial of problem, denial of symptoms, denial of diagnosis, or denial of treatment. Now let's briefly look into why people deny. So we look into reasons. Why do people deny? Not in a particular order. Like for each family, the reasons can be different. Important one is lack of awareness. Sometimes people are not aware that they have a symptom. It commonly happens in OCD. There are people who suffer from obsessive compulsive disorder where you get recurrent thoughts you don't want but keeps coming, and they read an article or see a video and they suddenly realize, oh, I didn't know that this was an illness. So one of my patients came and saw, like, he came to see me because he saw my video on OCD, and he said, until I saw your video, I thought I had a character flaw, because he had these thoughts of sexual images, sexual activity, which he didn't want. He kept trying to suppress, but he kept having, and he thought I'm a bad person. I had a character flaw. And he said, once I saw the video, I realized I was so relieved. I'm not a bad person. It's only OCD. So lack of awareness is one thing that people might not seek treatment, not like they might think, oh, it's something else. They may not even know it's an illness and they may not seek treatment. Another one for reason for denial is superstition, that they would say I'm depressed, but not because of what you say that there is some change in my brain. It's because somebody did black magic to our family. Or they might give a number of explanation, mostly superstitious explanation, or sometimes social reasons, like there are cultural beliefs which they have and say that is the cause, not a mental health issue. Then stigma. What if I say that my son or daughter has mental illness? What will people think? So best is to deny the whole thing and say, no, everything is fine. Sometimes people have depression, but the family members will say, no, no, we don't want to take treatment, because it's like once you take a medicine, it's like they have a problem and it's like confirming that they have a problem. So stigma is one of the major reasons why people or families deny symptoms, especially as simple as depression or as severe as schizophrenia. They would say, no, it's not there. There is no problem. They'll delay treatment. They'll deny it until things go out of hand. Stigma is also the reason why they deny symptoms and deny treatment. They don't want to take treatment because of stigma. There are two people waiting.
I have admitted that.
Yeah, you are there. Okay. Why is my thing not? Yeah, sorry. Yeah. Another reason for denial is fear. That fear of unknown. I'm fine with these symptoms. What will happen if treatment is started? What will happen if medicine is given? Fear of side effects. Common thing to deny medicine is, oh, this medicine will cause side effects. That's one of the common reasons they, for even antidepressant, they'll say side effects I'm worried about. Or sometimes they feel they'll get addicted to the medicine and they don't want the medicine. Fear of addiction is another thing. Then you have a whole lot of other fears that like addiction or side effect interactions. So those are the fears. Rather than getting better from symptoms, they'll say, no, no, I don't want side effects. And very funnily, that leave alone all the illnesses. People who take alcohol on a regular basis, cannabis on a regular basis, having psychiatric problems secondary to alcohol and cannabis, when we give medicine, they'll ask, does this medicine have a side effect? So I normally explain to them that alcohol was also a medicine. Alcohol has much more side effects than what these medicines have. So fear of side effect is one of the common thing that people deny. Another reason people say I don't want is they consider tablet as a daily reminder of illness. Like have a person who has become better, improved from symptoms, and now the medicine is continued for prevention. Because see, if it is a infection, we can have a vaccine. Whereas for an illness where there are chemical changes, we don't have a vaccine. We take medicine on a regular basis, like diabetes. So for them, I am all right. I have no symptom for the last 1 year, but the tablet is reminding me that I was ill. So that's one reason why they don't want to take the tablet. Sometimes that is another reason. That tablet as a daily reminder of a past illness. Then sometimes denial by the parents because of neglect. A child has a problem, but many times family members don't want to take adequate measures. It happens many times that the person is very tired. We'll ask them to do a vitamin D test or B12. 3 months later, the family would have still not done it. Like in terms of tests or in terms of tablets, sometimes the family delays buying the tablet and starting because of one is stigma, another one is fear or sheer neglect. So these are some of the reasons for denial. Now let us talk in detail about what we can do about it. So I'll stop the sharing here and I'll talk without slides from here. Okay. Any questions so far before we go to what can we do about denial? We talked about what are all the things we deny. We talked about briefly, we talked about why people deny and how they deny would be one is delaying, procrastination of consultation, procrastination of tests, procrastination of buying tablets. Sometimes people consult and like, for example, children with problems, children would have severe depression, we would have prescribed. 1 year later, the parents will contact us again with the same problem and ask you what happened. They said, we haven't started the medicine. We thought it'll just go away. So procrastination is one common way of denial. Or outright saying, we don't believe in this is easy because I can at least convince them. So we looked at how they do it. And now let us start talking about what can we do about it. So any questions so far from whatever we talked?
You could raise your hand or post in the chat box. Those who would like to ask questions of doctor.
Yeah, before we go to how to deal with it. Whatever we discussed so far, we can, any questions can be clarified and then we can go ahead as to what can we do.
Sir, this is Suresh Jaram here.
Yeah.
I have a question. I
Yeah.
just missed out that important point, what you said about the cannabis and the alcohol. Can you just repeat
Oh,
that?
I was just saying there are people who take cannabis and alcohol and have a psychiatric problem secondary to it, like a delusion, hallucination. When we give medicine, they will inquire about side effects of the medicine. Whereas alcohol and cannabis are basically chemicals used as medicine at some point of time, and they have much more side effects. So, like, they're not worried about taking alcohol daily, but they're worried about taking an antidepressant or one more medicine. I'm just making a point sometimes. Yeah. Any other queries? Yeah. Shall I go ahead then?
Doctor?
Yes, Sachin ji.
Yeah.
I'm afraid to discuss with family and the doctor about my symptoms. Someone will listen to me or people listen to me or listen. They have a camera in the house and I'm afraid that I'm always watched and I'm controlled by someone.
Yeah. Yeah. So the thought that you are always watched, controlled is part of the symptom that it's not real, but you will be convinced because for you it is real. Like they are watching, they are recording. But when they say we are not doing, you would not want to believe. You will say, no, 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 something is going on. So that's a symptom. You can actually talk, you can actually tell them about this is how I feel.
Okay, thank you, doctor.
Yeah. So I'll take this from here. So when a person denies, if it is like for different illness, the strategy will be different. So when a person denies, maybe because of psychotic symptoms, because they feel that somebody is watching them, somebody is controlling them, somebody is conspiring, it'll be, they will not accept a diagnosis. So what we do is depending on how much they are willing to accept. So if there are people who know that these are happening, I don't know why this is happening, then I normally tell them this is a symptom. I'll explain to them this is a delusion, this is a hallucination, and they might accept, they might not accept. So if they accept, then they are willing for treatment. But there are people who have no insight, who will not accept that there is an illness. For such people, in the first contact, I will not tell them about name of the illness or symptom. I'll tell the family, but to the person, I would say they will have some symptom that they're worried about, like lack of sleep, or the voices are too troubling. So I would tell them the voices are too troubling. You don't want the voices. I can give you some medicine which can help you to control the voices. But or you're not able to sleep well. Would you like to take a tablet which can help you to sleep well? So focus on a problem that they are talking about. They say, I don't have an illness, but I have a sleep problem. Can you treat it? Or I don't have an illness, but these voices are too annoying. So for them, rather than talking about diagnosis, I would say, okay, this is a problem. I can give you some medicine to make it better. And as they become better, many of them invariably will ask, why did I even have that thought? And that is the time to explain in detail about the symptoms and the illness. So normally I would see how acceptable are they about an explanation about symptom and the illness, and accordingly say, like not to everyone we say this is the diagnosis. So in psychotic symptoms, we explain depending on how much they are willing to accept. When you come to mania, the person is not at all going to accept that they are feeling high, and they'll say that that's how I am, it's not an illness. So what we do here is we at least some amount of damage reduction. We say one of the things they do in mania is they'll call a lot of people, talk to them. They're very active on social media, write a lot. So I tell them, see, 2 weeks later, you might have improved, but then you'll regret that you called so many people came to know you have an illness, or you posted a lot of stuff on social media. So we try to convince them, can you stop using social media? Can you stop posting them because you might regret later? Can you stop calling people? Can you give the phone to your brother, sister, or spouse for a few days so that you don't call up people? So we convince them, tell them in a way they accept that later you might regret. You may not agree with diagnosis, but at least can you control damage by not calling people? Then about medicine, because many times they'll say medicine is taking away my creativity. There are directors who will say, no, I'm not going to take medicine until I finish this movie. Or the writers who will say, I won't take the medicine until I finish the book. But the problem is, there is a condition called hypomania where the manic symptoms are very mild. Actually, the person will be more productive, more creative, but it doesn't stop there. It will become mania. Once it becomes mania, there are like, you get 10 creative thoughts, good, but every minute you get 10 creative thoughts. So even before you work on one creative thought, another creative thought comes and you are not able to do the first one. So you can't take any idea to its logical conclusion. So we explain that you are creative, but too many creative thoughts because of the illness process will make you not achieve anything. So can you take treatment so that it comes under control? So we try to convince them about the effects of what the illness can do, effects of what will happen if you don't take treatment, and try to convince. Invariably, people are convinced. So normally I would believe in explaining to the patient as much as possible and convince them rather than forcefully treating them. Like forcefully will come later if you're not able to convince. Usually most of them are convinced, because it doesn't mean that if you have psychotic symptoms, you're out of touch with reality. Many times people say, oh, he has psychotic symptoms, he's out of touch with reality. Actually, no. They are in touch with reality. They know everything that is going on. In addition, they are in touch with an altered reality brought in by their delusions and hallucinations. So they are dealing with two worlds, the world made of their delusions, hallucination, and the real world. They are not at all not in touch. So you can reason with them. You can explain the symptoms in a way that is acceptable, and you are able to convince. About people who have depression, sometimes I said they deny treatment because of various reasons. And once you find out this is a reason, you explain to them. If they have worried about side effects, you explain to them about side effects. Normally, honesty is the best policy, to actually tell them these are the side effects, and if they come, this is how we plan to manage. Will be better than a blanket, no, there are no side effects, because all medicines have side effects. So saying that there are no side effects doesn't help. It's just that all medicines have side effects. It's just, if there are side effects, there are ways of handling side effects, and we will do. The very art of medicine is about managing side effects in such a way that the treatment is not more painful. We have a dictum in medicine that the treatment should not be more painful than the original illness. Suppose you come to a doctor with a joint pain. The doctor gives you a painkiller, your joint pain is gone, but you have a stomach pain because of an ulcer due to the medicine. So that is something which we are very, very careful about. So we explained about side effects, we explained about the fear of addiction. Once we explain their concerns, then they are willing to take. So blanket statements of no, this is how you should be done, you should be taking medicine will not suffice, because we need to give explanation. And we need to also tell them about the limitations of knowledge, because sometimes patients will say, how does this medicine work? So when we explain the biochemistry of how it works, we also tell them this is according to the current knowledge. At this point of time, our knowledge is schizophrenia is due to increased dopamine in particular two tracks. Depression is to decrease noradrenaline and serotonin two tracks. This is the knowledge that we have now. This could keep changing. Sometime later, somebody will find out a new thing and totally we might have a different target. There are two ways of explaining to the family and patients. One is, as I said, talking to them about the limitations in our knowledge. This is what we know. These are the loopholes in our knowledge, and with the available knowledge, these are the medicines at this point of time. Some doctors say, no, if you say all this, patients and families will be suspicious. Doctor himself is not sure about that. We should tell the patient everything is figured out. We know this is the chemical problem. This is the treatment which will correct the treatment. It's like a car salesman who says everything is sorted out, the car is perfect. Another is to stand on the side of the patient and family and tell this is the knowledge we have, these are the loopholes. With the available knowledge, this is the best treatment. And there was a survey to ask patients and family which approach would you want, because doctors say no, don't say this is the limited knowledge we have. But patients actually appreciate a doctor saying this is the knowledge we have, this is the limitation, these are the loopholes. That giving us, oh, we know everything is sorted out. In medicine, nothing is sorted out. There are cancers which we still don't know why they occur. There are illnesses in mental health. There are illnesses in allergy, immunology, which we have no idea why they happen. So there are a lot of areas where there are huge black holes. We cannot say science has all the answers. In fact, we were wondering when COVID happened, memes were saying, trust science, trust science. No, I said, no, it's wrong. Trust is only for religion. We'll say trust religion. Science, we don't say trust science, question science. If we say there is a vaccine for COVID, question it. You say, are you sure? Is it a good vaccine? Does it have side effects? Is it completely proved? So you must actually question every scientific statement. So in between that movement of trust science, I don't agree. I say you should question science. You should be skeptical about everything. So when we talk about the limited knowledge we have, especially about an organ like brain, patients and families appreciate that that's the way to go, rather than giving them a blanket, oh, everything is sorted out and there are no side effects. That is like later when they realize there are side effects, they feel bad about it. So once you explain, people are willing to consider taking treatment. This is for both psychotic symptoms as well as for depression. Now, there are parents, when I suggest, there is a condition called ADHD, attention deficit hyperkinesis. There are books writing about, there is nothing called ADHD, this is a pharma creation and all, but if you actually see a child with severe ADHD, then you will know that this is something which has to be intervened. And unrecognized ADHD can lead to depression in adolescents. So when we suggest treatment for ADHD, we normally, can you mute the person? Yeah. When we suggest treatment for ADHD, what I do is parents are very, very concerned about treating children. So I normally tell them, read about ADHD in any website you get, even read about websites which say, don't give medicine. Write down all your questions, concerns. We will meet next time. I'll explain to you everything. Then if you are convinced, let's start medicine. Because just prescribing and say, I'm the doctor, you must take, no parent is going to give. Unless they have done their own research and they are convinced. So I normally tell them to read, ask. There are many doctors who get worried, angry about people Googling about symptoms. No, I would say no, it's a good trend. Google up, read everything, but then come back and cross-check. Like on the internet, this site says this, is it really true? So then I encourage that because people should independently look at information. And there is another way I try to convince people is there is something called Medline. Medline is like a search engine for published articles. So I tell them where to search. If they have a doubt about whether one particular medicine can cause this side effect, I teach them how to go to Medline and search for it. So once you take them into confidence, tell them ways of cross-checking evidences, then they are convinced. Now, one more category of people who will deny treatment is alcohol dependence. They will say, I have no problem, or I have a problem, but I don't want treatment. See, when they say, I don't have a problem, I don't want treatment, that's much more easier because we know where they stand and we can tell them why they need treatment, try to motivate them. The dangerous ones are who say, oh, doctor, you explained everything. I realize they agree with you completely. Then you know there is a problem because these are people who will say, oh, you explained everything. We agree with you. You opened my eyes and all that, and they will do exactly what they were doing earlier. So those who say, I have a problem, but I'm not willing for treatment, or I want to stop, but I'm afraid of the methods you tell, those people are easy because you can explain to them. Those who say, I comply with you everything and don't comply are the most difficult ones. Even those people who say, I don't want to stop are easier to handle because then you can at least focus on how to motivate them. That's about alcohol and substance abuse. One of the things I do about cannabis intake is they will argue, I've not been taking cannabis for 10 years, nothing happened. So I tell them to read about what cannabis can do, psychotic symptoms. And if psychotic symptoms don't happen, there is a much bigger problem called chronic amotivation syndrome. That is, they would not be motivated to do anything. That's because they are perpetually high and they don't want to exercise, they don't want to eat good food, they don't want to do anything. So that's something which is scary for most people. So explain to them about consequences and motivate them for giving up cannabis. That's about substance. So we just talked about schizophrenia, mania. We talked about depression, why people deny. OCD and anxiety, usually people want treatment, they don't deny. Then we talked about substance abuse. Then we talked about some children problem. So I think now we should go into a discussion where people have concerns and I can answer those. Like this was a broad overview of the topic. Now we can take specific queries and go forward.
Manjeet, there are a couple of questions.
Yes. Doctor, there are a couple of questions in chat box. I'll read one by one.
Yeah.
Yes. What should patient do for reduction of negative symptom and cognitive?
Yeah. See, what is for others who may not be aware what negative symptoms are. See, in schizophrenia, we call delusions and hallucination as positive symptoms. You might ask what is positive about it, but this is like, it's not supposed to be there, but it is there, so they are called positive symptoms. Negative symptoms are things which should be there, but not there. Like, for example, motivation. Like, we should have motivation, but in a person with chronic schizophrenia, motivation levels might be low. And sociability will be very low. They will be aloof. They will not want to mix. So for these, one of the things we suggest is occupational therapy, where as a group, if they go and do things which can be of their interest. That's why most occupational therapy will have multiple things. There will be carpentry, there will be office kind of work, there will be typing, there will be soap making. There are many different kinds which people are interested, painting. So they could do different things. And many of the occupational therapy centers also will have an evening time when they play together. So any group activity will be motivating each other. This is for people who have not taken treatment for a long time and they go into a chronic state. Nowadays, it's lesser and lesser because people start treatment earlier. So one of the thing is group kind of a setting will be very helpful. Exercises are very helpful because exercise can stimulate you to do stuff. So any kind of exercise will also help you to come out of negative symptoms. That is the emotivation, apathy, and all that. So that's something which can be done. Next question.
Next question is, what are the causes of virtual voice which are coming to a person?
Yeah. See, the voices which a person hears, which is not actually what he means by virtual is nobody is speaking, but I keep hearing voices. We call it as hallucination. So hallucination is a perception without any stimuli. That I hear voices, nobody's actually speaking, or I see somebody which actually nobody is there. So the hallucination happens because of certain changes in the brain. So now what happens in normal hearing is we hear, the ear picks up the sound and the inner ear will convert the sound into electrical waves. Small, when I say electrical, I'm talking about millivoltage kind of waves, which is sent through auditory nerve to the brain. And in the brain, in the auditory cortex, it is deciphered and understood that this is the voice that we hear. This is for voices which come from outside. Now, if there is a problem in the brain, usually it's a chemical problem. Sometimes you may not hear what is being spoken, but sometimes nobody is speaking anything, but your auditory cortex somehow, because of the chemical changes, will convert thoughts into sound and you start hearing voices. So many times the voices are from your own brain, like it's your own memories, your own thoughts, which come as voices, but different. It could be your own voice, it could be somebody's voice, known people, unknown people, but it's because of chemical changes in the brain. Because it's your own, because usually the hallucinations are always in a person's mother tongue or the person or the language which they are more comfortable with. If somebody's mother tongue could be Tamil, but they are very conversant in English, and the voices are likely to be in English. Like very rarely will you get a voice which is totally alien. So the seed for the content is actually coming from your brain, but the voices happen because of certain changes in the brain. That's why when we give medicine, the voices come down. It's not coming from outside, though it looks like it's coming from outside. So the voices are actually happening inside the brain, but it looks like it's coming from outside because of chemical changes. And one of the chemical changes that we have identified and we target with medicine is the dopamine pathway. So dopamine is a chemical which is secreted from one nerve cell, goes to the next cell in the whole pathway. In the nerve cell, the conduction is electrical, but between the nerve cell, it is chemical. So in schizophrenia, the dopamine circulation is high in two tracks. It's called mesolimbic and mesocortical. In these two tracks, when dopamine level is high, the symptoms happen. And the medicines will control the dopamine, block the dopamine level in these two tracks. So this is the cause for the hallucination. Now, apart from people having due to schizophrenia, where it is just happening, people who take cannabis can have hallucination. People who take opiates can have hallucination because they actually increase your dopamine and dopamine in a particular pathway. That's giving the kick. But when the dopamine also increases in mesocortical, mesolimbic pathway, that is when we get hallucinations and delusions.
Next question is,
Yeah.
adult ADHD is a recently accepted condition. It has many manifestations. Maybe some substance abuse is one of them. What is the way of identifying which is predominant?
Yeah. See, adult ADD has been known to us for 30 years, but recently there is awareness among general public that adult ADD exists. So some of them have had childhood ADHD unrecognized, and they go on to become adults. The hyperactivity comes down, but attention deficit continues. Very rarely that people would have ADD without a childhood ADHD. So the symptoms are difficulty focusing, difficulty concentrating. They can't read a book more than 3 pages, 4 pages. They will say, I just can't read. They will have difficulty even watching videos. They can't watch 10 minutes videos. Nowadays, adolescents tell me that they watch movies in 2x speed. They watch YouTube videos in 2x speed because they have so less attention span, they don't want to listen to somebody talking. So one is our attention span is coming down as a population. We are used to nowadays reels, which are less than 1 minute. After TikTok came, after YouTube, Facebook, everybody has reels. Those are more popular than long form videos. Than say long form, when I talk about, I'm not talking about 1 hour. Even 5 minutes, 10 minutes video, people say, oh, it's too long. They want one. The attention span as a whole is coming down. But in ADD, they have a problem with the neurodevelopment and the maturation of the nerve cell. There are these myelin sheds which is around the nerve cell. They are maturing slowly. So they have difficulty concentrating for long enough. So they will have reading problem. They can't read for long enough. They can't sit through a lecture for long enough. So normally they will lose the talk after 10 minutes and they will think about other stuff. Then they come back and they can't follow because they've lost 10 minutes in between. So typically they would say, I can't finish my tasks. I can't read a book for a long time. I can't watch a video for a long time. Those are the common symptoms they talk about, highly distractible. So if these are there, sometimes people have depression and they also say, I have ADD, but if depression is there, their concentration will be less. So if depression is there, normally we treat the depression, wait for the depression to go away, then assess your concentration and attention. If the attention concentration is still low, then we say, okay, fine. Then we can start treatment for ADD. So if it is ADD standalone without depression, then we explain to them, start, medications are there. There are attention eliciting techniques. There are some games which can actually improve attention span. So we suggest to them that. And so those are some of the things we do.
Next question is, can substance abuse be the cause for triggering psychosis and a psychiatric condition?
Yes. Substance like cannabis can trigger, substance like opiates can trigger, and substance like even there are things called Huns, which is actually chewing tobacco, but people add all kinds of things. That can also trigger psychiatric problem. So substance for most people can trigger psychiatric problem. Even alcohol over a period can cause suspicion. Alcohol can cause withdrawal hallucinations. Alcohol can cause delusions in the long run. So substances can cause psychiatric problems.
Next question is, the reduction of ADD, what should patient do?
See, there are attention eliciting techniques like, say, for example, you could, for a child or adolescent, you can have beads of different colors, sort them out. Then what you could do is letter cancellation. Like you take a newspaper, cut all the O's or cut all the A's. That's an exercise in improving your concentration. Or drawing, painting, anything that requires concentration, doing it more. Embroidery, all that will improve your concentration. So those are some of the things which can enhance your attention concentration. Then there is a game called Brain Workshop. I'll share the link with you. It's a free game. Very boring game, but if people with ADD do it regularly, their attention span will improve very well.
Next question is, does amisulpride cause diabetes?
No, it doesn't. Amisulpride doesn't, but olanzapine can cause. I would say rather than cause, it can trigger. In a person who is already susceptible, any medicine can trigger. So amisulpride is not directly linked, but what happens is many of the antipsychotics can increase appetite. So increased appetite can lead to diabetes. So the proven connection is with olanzapine, to some extent quetiapine, because quetiapine can cause your weight to go up and indirectly can cause diabetes. Amisulpride, there is no direct correlation to diabetes.
Next question is, some people have a habit to rush to a doctor immediately. It is said that individuals need to develop coping skills or resilience like we do in other physical problems. So how long one should wait for his body or mind to address the problem? I'm asking from patient's point of view.
Yeah. I would say you should see a doctor when you think, I had enough, I don't want to suffer anymore. So it's up to individual's tolerance level, because we don't just give medicine, we also teach coping skills. So it's not that seeing a psychiatrist means immediately medicine. No, if for a person with anxiety, person with mild to moderate depression, sometimes we don't use medicine. We teach them coping skills. We teach them how to improve your resilience. So those are things which we teach. In fact, there are many of these things have to be taught at school and college level. So the analogy is, sometimes people will start exercising only after they get a diagnosis of diabetes or a hypertension. Otherwise, you tell them to exercise, walk regularly, they won't do it. So similarly, we don't have to wait until we get a psychiatric diagnosis. We can learn a lot of coping skills, improving resilience, even without a psychiatric diagnosis. That's why we try to incorporate many of this in school curriculum, where teachers can talk about stress management, improving resilience, so that you don't have to wait for a diagnosis and then do this. So some of these are preventive, which need not be with the doctor, which can even be with teachers. Teachers can be trained to teach children how to manage some of these. So you reaching a psychiatrist is only when you say, I don't want to suffer anymore. That is the point you need to see a doctor.
There are many questions, but now I'll just take it which are related to this because we have very few minutes left. How can we help patient of schizophrenia to develop insight about his illness?
Yeah, see, mainly by explanation. Explaining that, and as I said, somebody is wondering, why am I getting these thoughts? It looks very real, but I also am doubtful it may not be real. It's the time for you to explain that it's an illness. These are symptoms. But if they are floridly psychotic, they will not be accepting. Some of them, I would say, there are patients who say, I don't agree with you at all, but I'm willing to take medicines because I'm not able to sleep. So I say, I appreciate, even though you're not willing to accept, I'm glad you are accepting to take medicine, and you will see for yourself. So 2-3 weeks later, they'll say, why did I even hear the voice in the first place? That's a good time to explain. So explanation will be based on what stage of illness they are. And then convinced, as I said in the beginning, if they are agreeable, you can explain the whole thing, or you can pick a specific symptom they are bothered about and say this medicine will help there, and convince them to take accordingly. Or sometimes in mania, I say, please take for 2 weeks, see how it is, then we will talk about whether to continue beyond that. So that kind of explanation will invariably make them accept.
Doctor, generally what we find that if a person who has some mental illness, but he has very good, he's performing well in his, if he's a high functioning person, so he doesn't accept that. He says that, I'm doing everything good, or maybe rather better than everybody else. So I don't need any treatment. So what to do in this condition?
I'll give an example. Now, a person with schizophrenia invariably knows I have a problem, they are willing to take treatment. There is a condition called delusional disorder. Now, here, there will be only single delusion or a group of connected delusions, and everything else is all right. No hallucination, they are able to work very well, absolutely no problem. Information processing is correct. Invariably seen, say, for example, somebody has delusion of infidelity about spouse, that the person is convinced that the wife is having affair with somebody else, convinced to a delusional level. Everything else is fine. And the person will refuse treatment. And for the spouse to convince, say, for example, the husband is suspicious. For the wife, it's even difficult to convince his parents that he has a mental illness, because the parents will say, he is working normally, he's driving normally, everything is normal. If he's suspecting you, then maybe there is something wrong with you. So in delusional disorder, it becomes very, very difficult to treat them. And they will refuse to come to us. When they come to us, it's a very, very uphill task. And they respond very well to medicine, but the problem is they will refuse to take. In schizophrenia, though the symptoms are florid, at least they are accepting to take medicines and they all improve. Delusional disorder is very tough. So sometimes we resort to giving medicine with some amount of pressure, admission, and giving them medicine, so that once the symptoms come down, then they readily accept. So first time we might admit and treat them. At that time, we need the family's consent. If the patient is not willing, we take the family's consent, because we can't admit without consent. And now the rules are very strict, because people can abuse this rule to keep somebody under detention. So two psychiatrists will have to agree that the person has an illness. You can't admit just like that. Even if you admit within 24 hours, you should have got a second opinion to safeguard that, yes, they have an illness. So sometimes admission helps. Sometimes we don't talk about it often, but we do. Surreptitious medicine, giving medicine without the patient's knowledge. I don't resort to it, because suppose somebody has an illness, psychotic illness. The family gives medicine without their knowledge and the person improves. Then the person says, yes, I agree, in January I had this problem, but I became normal on my own, and they won't take medicine. You can't give preventive medicine. You can't tell them we gave medicine, that's why you became better. So normally I would want the person to take medicine with their knowledge, whether they are willing or not. I'm taking it, okay. I'm not agreeable. I don't agree with your theory, but I'll take it because you're assuring me it helps you. That's better than giving without knowledge, because then it becomes very difficult to give follow-up medicine. Now, some parents do this mistake of, they'll start giving surreptitious medicine without the patient's knowledge, and they just continue without consulting the doctor. So what would have happened is, say, for example, a medicine A, they might have needed 400 mg for the symptoms to come down. But once the symptoms come down, you can keep decreasing to 300, 200. But parents don't consult psychiatrists, they just continue on 400 for a long time. So that's a mistake. So we are a little hesitant to give without knowledge. But in rarest of cases, we do give that. There are liquids which are colorless, tasteless, which we give, but I normally try to keep it to as minimal duration as possible before we meet the patient and convince them and start oral tablets.
Okay, doctor, now we can take one more question.
Yeah.
Okay. What if the patient has kept himself totally kept himself socially isolated?
Yeah, like they cook on their own, they don't eat what is made at home. In which case they can't give surreptitious medicine also. No other go but admission. If the person is cooking separately, staying separately, then we need to admit and treat. Yeah, Ganesh.
I don't think it's a follow-up to the earlier question. It's just basically a question that a person is afraid to step out of the house, a kind of a phobia. And
Okay.
so he
Yeah.
doesn't interact with. Yes.
Yeah, see, sometimes they might not want to come and see a doctor because they're afraid they'll be admitted like last time. So many of us nowadays say you can see us online so that the fear of admission is not there. And then they address their concern. Why are they not going out? Is it because of their fear that they could be attacked? Is it because, like, you address their concern and take care accordingly? I can take more questions. If there are people wanting to ask questions, I can take.
One question is, once psychiatric medicine starts, especially considering schizophrenia, what are the possibilities of stopping medicine, and when patient has very strong belief that my medicine could not stop?
See, in some of them, there can be one episode and never again. Some of them can have recurrent episodes of even schizophrenia. Some of them can have some symptoms remaining. Most symptoms have gone. So each person's course is different. So if somebody has one episode and never again, we are able to taper the medicine slowly and stop at some point of time. There are some people who are able to do that. And if at all they get a relapse 5-6 years later, we can always treat. But some people, when we try to taper, get symptoms again. So they might have to be on a particular dose for much longer time. So it's not that everybody with schizophrenia has to be on long-term medicine. Some of them, with one episode, we actually try to keep them on a very minimal dose. Some we are not able to. When we reduce itself, they will have symptoms, so they will have to be on a fixed dose for a much longer time. So it will vary person to person. But usually we keep trying to decrease so that we can keep them on as minimal dose as possible. As I said, if it's a first episode, less than 6 months, we can even try stopping. If it's only 2 years, 3 years, long-term illness, then we are wary of stopping. We will want to keep a low dose.
I think we have covered most of these things.
Is ECT is essential?
Sir, if the ECT, the indications are, if it is not, ECT is given, absolute indication is severe depression with suicidal risk. So if a person can be taken care of with medicine, they improve. Only if they don't improve with 3 or more medicines, then ECT can be given. ECT is a very safe procedure used in schizophrenia and in severe depression. But nowadays, with better and better medicine, the incidence of ECTs have come down a lot.
Thanks, sir. Please, thanks.
Sir, what is cannabis?
Cannabis is marijuana or ganja. One of them is said second part of ADD not answered. What is the question again?
Second part of adult ADHD is not addressed.
I said adult ADHD options of increasing attention span. There are many methods. Then there are medicines which can increase attention span. These are the two things which we do.
I believe this is related to conditions like developing anger and spontaneous anger without visible cause. As correct me if I'm wrong.
What is it?
When the emotional relationships get strained due to ADHD,
okay,
and there are angry outbursts caused by.
No, not at all due to ADHD. Somebody has said second part of ADHD question. What is the second part?
Could you please elaborate?
Yeah, could you unmute and ask? Sir, can you unmute and say what do you mean by second part of ADHD?
I have put it in the chat again, doctor. I'm saying that substance abuse could be combined, and which is the dominant, or does it go together?
Okay.
How do you know? That is one of the manifestations.
Yeah. See, when we see both going together is, in childhood, a child could have ADHD, which was unrecognized by parents or the teachers. There is another condition called SLD, specific learning disability or dyslexia, which also sometimes the teachers and parents don't recognize. So they keep telling the child, you're not trying enough, you're not studying enough, you're not working hard. If you worked hard, marks will come. So the child says, no, I studied for 4 hours, but I'm not able to, and parents will not accept. So if there are unrecognized ADHD, that can lead to depression in adolescence. And the sad thing is sometimes even the depression is not recognized by the parents, and they take substance and they feel good, and they might take substance as a way of feeling good. So the alcohol or cannabis is taken to feel better. So when you go back, an adolescent is brought for cannabis use or alcohol use, you go back in history, you find there was depression which was unrecognized. Then you go back and see why were they depressed. That's because an ADHD was unrecognized. That's a big, big tragedy. So normally we talk to teachers about diagnosing ADHD, diagnosing ADD, the dyslexia in time, so that you can avoid depression, you can avoid substance abuse. So the connection between substance abuse and ADHD is this. Substance abuse do not cause ADHD. It's the ADHD which can lead to substance abuse through depression. That's the direction we see.
Sir, one question.
Does that clarify?
Sir, one
Yes,
question.
thank you very much.
Yeah, sure.
Sir, quetiapine and olanzapine are good medication for negative symptom, and modafinil is good for ADD treatment.
See, modafinil is not for negative symptoms. Modafinil is for sleeping sickness. It makes a particular tract alert. So there is a condition where they'll be pathologically sleeping. It's given for them. So it's not for ADD, not for negative symptoms. Sometimes some psychiatrists use modafinil along with sedating drugs. I personally don't approve. I would say, why give a sedating drug and then give modafinil to keep a person awake, alert? Rather try to avoid a sedating drug. So I don't use modafinil at all. Its primary use is in sleeping sickness. There's a condition where there can be pathologically high amount of sleep. That is the primary indication for modafinil. Now there are a lot of students who abuse modafinil before exams, and that can also lead to a lot of consequences. Not very helpful in ADD.
And sir, quetiapine and olanzapine are good for negative symptom.
To some, yes. Most antipsychotics will help in both.
There was a
So
question.
Naltrexone.
जी sir. So are essential for what are the side effects of this drug?
1 second. Is it naltrexone?
Naltrexone.
Okay, naltrexone. Okay, naltrexone is an opioid drug, but doesn't have the actions of opioid. So why we use that is if somebody is abusing heroin, brown sugar, any of the opiate drugs, morphine, pethidine, or buprenorphine, if they want to stop, what we do is first, when they stop, we give them a particular drug called clonidine to take care of the withdrawal. Then if they are willing, we start them on naltrexone. Now, naltrexone, how it works is, the heroin or any of the opiates work on the brain through what is called as opiate receptors. There are 3-4 receptors in the brain, 3-4 different types of opiate receptors where the opiate drug goes and acts. That's how they get the pleasure. So naltrexone will not give you any pleasure, but they go and act on the opiate receptors and block it. So if a person is taking naltrexone, even if they have an urge and take, say, brown sugar, they will not have the effect. So the theory is expectation is they will stop using a opiate because they are on naltrexone. But if they are not motivated, they know that naltrexone is preventing the high, so they will stop naltrexone. So we will stop naltrexone only if somebody is well motivated to stay away from opiates, and it's very effective. When somebody is well motivated, naltrexone really helps. It's
I
also
But-
used in
but-
alcohol dependence.
would request
It brings down alcohol craving.
I would request the participants to restrict themselves to symptoms and addressing them, and not specific drugs.
Yeah.
I think that will have to be taken offline. So, any questions related to symptoms? There was one.
But the patient is not taking any drugs. Why a doctor provide him for this treatment? Naltrexone.
Which one, sir?
Naltrexone.
See, I don't know the specifics of this particular patient. Naltrexone is also useful in alcohol dependence, in bringing down craving and all that. So, other than alcohol dependence and opiate disturbance, I can't think of any reason why the doctor has given. I don't have any information about the specific patient or the case, so it's very difficult for me to say why they started.
Okay, sir.
So I had a question about an article that would help understand the long-term abuse of cannabis.
Yeah, I will get one and I'll send it to Mr. Ganesh, who can send it to everyone.
Thank you
Offhand,
so
I
much.
can't think of, but as soon as I
Right,
get
sir.
one, I'll
Thank
send
you
it.
so
Sure.
much.
Yeah.
I think we are done with most of the questions. Doctor, would you like to take last question? That is,
Yeah, sure.
patient is taking medicine for last 2 years, but restrict to his room all the day. What to do?
They need to make things interesting. Maybe initially they can start with motivating the person to go for walks or go for walks together. So first find out why the person is like, is it because of lack of motivation or is it because of fear of going outside? So accordingly, they need to do that and encourage them, take them out few times. I would want to find out why the person is keeping themselves to the room, and accordingly, if it's fear, manage the fear. If it is negative symptoms, no motivation, manage it. If it is depression, manage it. So accordingly, whatever is the cause, we have to manage accordingly.
Sir, one question. Stimulants are the medication for ADD adult?
Yes. There is one non-stimulant, then there are 3 stimulants, but only one is available in India. The non-stimulant is available all over the world. Stimulant, there are 3. Only one is available in India and rest of the world. The US alone, those 3 are there.
Thank you so much for being with us today, Doctor.
Yeah.
Thank you for being with us today.
Sure.
Thank
Thank you for calling me.
Really appreciate the insights you shared. And anybody who I'll has any more questions to ask, we can take that offline and probably arrange some kind of a follow-up for those people.
Yeah. Or Ganesh, if you send me some message or email also, I can answer and you can post. If you have a group of volunteers, you can post.
Thank you, Doctor, once again.
Okay, thank you.
Very much for being with us.
Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you for the interaction.
Thank you.
Thank you.
Bye.
Thank you. Thank you.